Hello, everybody. Yes, this webinar is on. Thank you so much for being here today. We are here together on Friday evening for another CTS educational webinar. Tonight's webinar topic is comprehensive COPD care. Our speaker tonight is Dr. Michael Schivo. Tonight's presentation will also provide an opportunity for a live Q&A session after about a 35 to 40-minute presentation. We ask that you all use the Q&A Zoom functionality. You can find that functionality typically at the bottom of your screen in the Zoom interface. It's a small two speech bubble icons with the letters Q&A below it. So we ask that you type in your questions at the end of the presentation, and hopefully we'll have some great questions for Dr. Schivo. Again, as we said today, we are very fortunate to have Dr. Michael Schivo to give our presentation on comprehensive COPD care. Dr. Michael Schivo is Associate Professor of Medicine, Co-Director, Comprehensive COPD Clinic and Director, Internal Medicine Research, Residency Research Track, Division of Pulmonary, Critical Care, and Sleep Medicine at the University of California, Davis School of Medicine. Today's presentation was developed by the California Thoracic Society, Dr. Schivo, and in collaboration with Electromed. So thank you, Electromed, for helping support this event. Dr. Schivo, I'm going to go ahead and turn it over to you. I believe you'll have to unmute yourself if you have not already unmuted. You potentially might have to go out of full screen.
There we go. Can you hear me?
Perfect. We got you.
Okay, excellent. Jason, thank you very much. Thank you to the California Thoracic Society for inviting me. I'm glad everybody's here. And thank you to Marina from Electromed for finding me and asking me to speak as well. So this is really great. I actually was part of the California Thoracic Society for many years. I helped to plan the annual conference way back when it was in Carmel. And I think I did that for about 5 years. So it's a lot of fun to be here as a speaker this time. So today I'm going to talk to you about COPD care at UC Davis. And this is something that has evolved significantly over the past couple of years. And I hope to tell you about what we do and then also provide some education on how we approach COPD that you might find useful. Okay, I have no financial disclosures. I may mention specific brands of medications or inhalers, but I don't have any financial interests. Okay, so I don't need to put this up here. You all know why COPD is so bad. No doubt you all take care of COPD in abundance. But I found it kind of interesting that from a study from a couple years ago that it probably costs $49 billion annually to take care of COPD. And a lot of people don't realize that it is really the most costly chronic illness. So this is a big deal. Most of that is driven by hospitalizations, both in the ICU and on the floors. We know that people who are hospitalized for their COPD are at more of a chance to die. We know that their disease intensifies, and we know importantly that their comorbid disease, usually cardiac disease, intensifies as well. So we'll talk a little bit about that. Why else is COPD so bad? It's difficult to control. It's difficult to treat. We all know that. A lot of primary care practitioners aren't familiar with spirometry enough to really diagnose COPD when someone comes in with subtle complaints. So it's underdiagnosed and then, as I said, difficult to control and treat. It coexists with a lot of comorbidities. I'm going to spend a bit of time talking about that today. You're all very familiar with the complex medication regimens that patients have to endure, both in confusion in how to use them, but also in the cost. A lot of these medications may or may not be covered. Different ones are covered by different plans, et cetera. We like to say the patients are non-compliant. We like to say that patients aren't taking the medications we're prescribing, but when you really look into it, there are a lot of reasons for that we can help with. And then, treatment guidelines do exist. Some people adhere to them, but what we try to do is customize our care to the individual patient. In 2014, the Center for Medicaid Services said, we're going to penalize hospitals if there are too many readmissions for the following chronic illnesses, and COPDs right there. One of my mentors and one of the people who had sort of the vision for the COPD clinic knew this was coming and actually developed an inpatient program to help manage COPD in the acutely exacerbating patient. And I'll talk about that in just a second. So I like to show this slide. I got this from my colleague, Dr. Kuhn. This would be sort of the typical hospital to home to clinic course. And with respect to COPD, we can see symptoms there when they're in the hospital having their acute exacerbation. Hopefully they get excellent care and then they go home. And that home is this big gray box. And in this slide, we can see that symptoms are getting better and eventually they show up in the clinic. The reality that we're probably all aware of is the symptoms probably look more like this. And that depends on the time the patient's home, how long it takes for them to get follow-up. Do they understand their new medication regimen? Do they understand their new medication regimen and are they able to reconcile it with all the other medications they have at home? It's a heavy lift for a lot of patients, not to mention clinician understanding. You couple that with the fact that a lot of patients get care at other facilities that are outside our own hospital systems, and it just becomes more confusing. So Sam, he's pictured there on sort of the left-hand side. He said, we've already developed a really, really good asthma clinic. Let's do the same with COPD. And Dr. Kuhn and I, who are right next to him, were academically interested in COPD. And so he said, why don't we start this outpatient COPD clinic? In addition, he had already started the inpatient one, which I'll talk about there. And so we really wanted to bridge that gap. And that's how we found our home. So for the inpatient side, Sam started this several years ago, and this was in anticipation of the CMS penalties. And he started the UC Davis ROAD program. ROAD, which stands for Reversible Obstructive Airways Disease, initially started inpatient, and it was led by respiratory therapists. And that was sort of a stroke of genius because they work with patients all the time. They understand inhaled medication. They understand some of the nuances with that. And their mission was to improve acute care of COPD and help with the transition of patients leaving the hospital. So what do? They are a group, there's probably about 7 or 8 of them, and I may be misrepresenting that. There may actually be more at this point. But they screen in the EMR and the electronic medical record. They look for people who have come in with a diagnosis of COPD or a secondary or a tertiary diagnosis of COPD. They look to see who is on scheduled bronchodilators, who's on IV steroids and antibiotics. And they pick those patients, they look through their chart, and they literally go to the bedside and figure out what they can do with the patient. We have also enlisted the help of the hospitalists and the whole team of people who take care of patients. Many of them now know that if they have a COPD patient, again, as their secondary or primary diagnosis, they know to contact the inpatient ROAD team. We are now expanding that out to surgical services, so we really do have buy-in from the whole hospital. So the respiratory therapists go to the patient's bedside, they assess their symptoms. If the patients are encephalopathic, they talk to their families. They look at what medications they have. They look at whether they understand how to use their medications. They also assess for adjunct treatments. Is this someone who potentially needs non-invasive therapy, non-invasive positive pressure to potentially go home with? Are they able to clear their airways? Do they need oxygen? And importantly, the inpatient respiratory therapists contact the discharge pharmacy. And we have a very, very good, it's called Transitions of Care Pharmacy team. I learned about this about 3 years ago when I was giving a talk that was sponsored by the COPD Foundation, and I met the pharmacists. I actually did not know they existed. They are wonderful. They have a whole swath of people that work with them, interns and technicians. They go top to tail through the patient's medications, in particular paying attention to their respiratory medications, but they also do cardiac and some other things. And importantly, they reconcile what medications they have at home with what they're being started on or what's being changed in-house. They look at barriers. They look to see, can the patients actually afford these medications? Are they able to use these medications? Is it time for them to go to all nebulized therapy until they sort of get back on their feet and they can handle some of the other ones? They do test claims to see if their insurance will cover it. And then they actually help the patients contact individual pharmaceutical companies to see about cost assistance programs, and many of them have them. And then they follow up with a call afterwards. This data is not published, but this is what we used internally more for sort of quality control as a benchmark, where we're actually doing what we said we were going to do. And on the graph on the left there, you can see that the readmission rate did in fact drop. That split between 2011 and 2012. When you look at the average length of hospital stay, that also reduced. And that was in part because the respiratory therapists were returning every day, educating the patients and customizing their medication regimen. So that's the inpatient team, and they've done a wonderful job. And some of my other colleagues can speak about that at length. I'm going to talk a little bit about sort of how we manage these patients and other patients who were referred to our clinic from the community in our COPD clinic. Here's the three of us on top. Myself and Dr. Kuhn are the principal physicians in the group. Sam was initially there. Now he's there more for moral support and helping shepherd us. This is Marcy and Crystal. They're two of our wonderful respiratory therapists. They're at every visit. They definitely see the new patients. They often will see follow-up patients if they're needed. There are many other respiratory therapists. I just didn't get all their pictures to put here, but we really have a good group of people that really make this clinic work. And down here, we have two of our clinical research coordinators who consent patients for projects that we have going on and consent patients for us to use their data in our registry. So I took this list really from the GOLD initiative, and this is how they would recommend how we would work up and treat somebody with COPD. And I'll go over this again and again. But basically, we always look at their exacerbation risk. We know that the people who have the highest frequency exacerbations are the ones who have the poorest quality of life, who are more likely to die, who are more likely to drive up healthcare costs. Not that that in and of itself is a big impetus for what we do, but it kind of underscores how sick these people are. We always look at their symptom burden. We always, of course, look at what we can modify. And this is something that we focus a lot on that primary care physicians may not have a lot of time to do. Smoking is one of the big ones there. We customize treatment. We look heavily into comorbid conditions. And then, of course, we have our clinical study aims. This is kind of the process of how it goes. So in the pre-clinic visit, we always try to reach out to our referral base, whether it's the hospital or not, to make sure that things like pulmonary function tests have been ordered and hopefully completed by the time they come see us. If people suspect structural airways disease, a CT scan is always very helpful. When we get the patients in the clinic before we actually see them, that's a great time for them to fill out their symptom questionnaire, to answer brief questions about smoking and other things. We then have our respiratory therapists go in. And as I said, they really go over the medication regimen. They really go over the inhalers. They provide a lot of feedback to us to help streamline patients' medications. They listen to them if there's cost issues. We then go in there, it's myself or Dr. Kuhn, and then we do the full sort of history and physical, and we really focus on, do they have comorbid disease? And of course, is there any advanced treatment that we can offer them? Our clinical trialists will go in afterwards. Unfortunately, for the past several months, we haven't had them because they've been kind of diverted to COVID studies, but we hope to get them back soon. And then of course, when the patient leaves, we need to make sure that they have the appropriate diagnostic tests ordered, that they have referrals if needed. This is just another version of what I kind of went over, and this is from the gold data set or slide set. And I'm going to kind of go through how we actually do this when we initially assess someone. Obviously, our initial management is what it is. Sometimes we may have pulmonary function tests. Sometimes we need to order them. But we always get the patients back at least once. And I would say on average, we see patients 3 to 4 times before we sort of release them back to the community. And we're always reviewing their symptom scores. We're always reviewing if they continue to smoke. We're always reviewing their ability to sort of self-manage their symptoms. And we're adjusting. So we're kind of going in this cycle over and over each time. And that added level of repetition seems to make a big difference. Some of the first things we look at is symptom burden. And you may be familiar with this. This is a COPD assessment test. This is very easy to administer in a questionnaire format. And interestingly, patients are very adept at filling out the numbers, but I haven't seen one who actually will calculate the score. And that's okay, I can do that. That's not a problem. It's just kind of a funny thing that they do. So why do we use this? It's actually really easy to use. We generally don't need to ask the patients all these questions. They generally can figure this out themselves. But it correlates well with much more robust respiratory questionnaires. So I use the example of the St. George's Respiratory Questionnaire there. This actually correlates very well with it. Plus, because it's multidimensional, I can see based on this if someone is producing a lot of mucus, and that's part of the phenotype of their COPD, or I can see if they have sleep disturbance. And we'll talk about that in a bit. We try to look to see if there's, at a follow-up visit, if they've dropped their score by about 2. That's where it's probably clinically important. Of course, we would like more than that, but that also lets us know if we're on the right track with therapy. We do use the MRC dyspnea scale. I personally don't find this terribly helpful because it's not quite as detailed and the patients seem to be doing well with the CAT test. Exacerbation risk. This is a big deal. When we think about what is the single thing, if you could distill it down to one thing that predicts future exacerbations, and that is a history of prior exacerbations. This is the ABCD assessment tool, again, put forth by Gold. And this really shows how we look at these patients. So the first thing we do is we clearly look at their spirometry and we give them a grade. And that has some important prognostication information, but it certainly is not the whole picture. We look at their exacerbation risk. If they've had 2 or more exacerbations or 1 serious exacerbation in the last 12 months, they are at high risk. They would fit into the C and D category here. If their symptom scores are high, they would fit into this B or D. And I'm going to talk a lot about this B category and this D category. And those are probably the patients that we want to get to the most, principally because they may or may not have a high exacerbation risk, but they also tend to hide occult cardiovascular disease. We don't see a lot of C patients. That's a little bit unusual. Other things that we look at when we're looking at exacerbation risk, this is from the ECLIPSE data set. And this is the one that looked at if you had a prior exacerbation, you're more likely to go on and have a future exacerbation. Heartburn's in there. And we do actually ask a lot about heartburn, and it's pretty impressive how much heartburn we uncover or dysphagia that we uncover, swallowing disorders that we end up referring out for treatment. Other predictors that we use of acute exacerbations, inflammatory biomarkers. This was a study, and I'm gonna misrepresent this. I wanna say it's Dutch. I know it's Scandinavian, but it's escaping me right now exactly where it's from. But they looked at 3 biomarkers. They looked at CRP, fibrinogen, and white cells. And they noted that if all 3 were elevated, now granted this was a much smaller percentage of their population, there was a much higher risk of having frequent exacerbations. We collect, we collect this data in stable COPD. As of yet, I haven't used this as the sole criteria to predict who's going to go on and have a future exacerbation, but it potentially will be useful. What about peripheral eosinophils? So, we see a lot of people, as I'm sure you do, who have this overlap disease where they have COPD and they have features of asthma. And there is some data that if you treat patients with a high peripheral eosinophil count, it may actually help to reduce acute exacerbations of COPD. It's not terribly robust data. It does come from drug studies, but it's something that we pay a lot of attention to, especially in this overlap group. We try to be fairly sparing about using inhaled corticosteroids for patients with COPD, small increased risk of pneumonias, but in some patients who have high eosinophils, it can actually be very useful. Okay, smoking. I like to put this here. I mean, we all know smoking's bad, of course, and we know there's a lot of terrible compounds that are rendered when you light things on fire and inhale it. But one thing we try to pay attention to is what else people are doing that they might not admit to. So if you ask someone if they're smoking cigarettes or if they're smoking, oftentimes people will say, no, I quit. But what they may not tell you is, but I still smoke cigars, or I smoke hookah. And I put hookah here because we actually have a fairly good size amount of people that we see who come from other parts of the world where hookah smoking is more common. And interestingly about hookah smoking, it is often done with tobacco. It's filtered through a water column. What that does is it actually makes the smoke a little bit less noxious. And so people tend to inhale it deeper and hold on to it. And it's part of almost like a ritualistic kind of thing as well. And what's interesting when you compare sort of ounce for ounce cigarette smoking to hookah smoking, this is far worse for your lungs. The data is not great for that, but there is data to suggest that there's more of a chance of developing emphysema with that. I put cigars here because cigars are interesting. If someone previously smoked cigarettes and they switch to cigars, they're much, much more likely to inhale that cigar smoke. It's called secondary cigar smoking. Cigars are constructed with a fairly non-porous wrap around them. And what that does is it doesn't allow a lot of oxygen to entrain in. And so you actually get hypoxic combustion, which renders a lot more harmful chemicals than combustion with oxygen. Also, what's kind of interesting about cigars, whether someone inhales or not, the nicotine in cigars gets a little proton on it, and it makes it absorbable in the mouth. So cigars are actually really, really harmful. Pays to ask about them. I put this slide here just to underscore that people come from all over the world, and some people don't have a primary tobacco smoking history. But if they're from a developing country, and in particular, if they're a woman from a developing country, they may actually spend a lot of time in poorly ventilated structures, heating their homes with biofuel and cooking. And you can see from this picture, there is a lot of ambient smoke that this poor woman's inhaling. A lot of people use organic substances. This would be dried cow dung, and they light that on fire. And so there's also the implications of aerosolization of toxins and gram-negative rods and all sorts of other things. I always get this question, what about vaping? Not a lot of great data with vaping and COPD. This is a recently published report. It was based on self-reported symptoms. There appeared to be an association. Obviously, a study like this has bias in it and has some flaws to it. Vaping probably hasn't been around long enough for us to show causality, but perhaps we can start seeing an association here. Alpha-1 antitrypsin deficiency. So, it's well known that a small percentage of people, it's fairly small, may have a PIZZ phenotype in low levels, and that certainly can promote COPD, emphysema in particular. That's probably underrepresentative of the actual number. As we start testing people more, which is in line with sort of recommendations, we might actually see a higher percentage of that. Replacement therapy seems to work. It seems to slow down the rate of lung function loss. I will tell you that anecdotally, I have a number of patients who are on replacement therapy who actually tell me they feel better. I don't know if this is a function of being on therapy as a placebo effect. I don't know if this is an actual effect. It hasn't been well studied, but we check everybody for this. In particular, Dr. Kuhn, who sort of runs our alpha-1 antitrypsin kind of subgroup in clinic, he has a couple studies looking at mixed phenotypes, so PIMZ, PIMS, and whether replacement makes a difference. So extrapulmonary COPD. Obviously, we know what the problem with COPD is. It's difficult to understand. It shows up in a bunch of different ways. The manifestations are heterogeneous. The symptoms are hard to control. But what people may not recognize is that extrapulmonary manifestations are very common. And I say cardiovascular disease because that's probably the most common, but there are a number of other ones that I'll show you in a bit. And in fact, these extrapulmonary manifestations might be driving a lot of the symptoms. And these can be really difficult to tease out. All right, who cares about that? Well, you know, I'm going to show you some data where treatment of COPD may actually reduce cardiovascular risk, including mortality. And treatment of cardiovascular disease may actually reduce acute exacerbations of COPD. So it is important to recognize this, and it's important to pay a lot of attention to this as a pulmonologist. Plus, it gives us a better global understanding of COPD, right? If we know what other diseases people have and we pay attention to that and we think of them as sort of linked with their COPD, that will impact what we choose to treat them with. We may improve their quality of life. And as I said, we might improve their mortality. I like this slide. I'm going to show you another one after this. This is from the gold slide deck. And here's a lung right here. It's being injured by a cigarette there. There are all sorts of diseases that have been linked to COPD. One of them I think of as lung cancer. It's not really extrapulmonary, but that there's obviously really good data with that. But this concept of spillover of inflammatory mediators, and there are a number of different bioinflammatory sort of markers that we can see in the peripheral blood that come from the lung. And the idea is that this spillover may engender inflammation in other organ systems. So the heart, bone demineralization, metabolic issues, etc. This is another slide. It's called the comorbidome. I love that. So if you plot COPD in the center right here, and you think of this blue line here as a relative risk of 1 of associated disorders, and everything inside here has an increased risk when associated with COPD. You can see these different spheres here, and the size difference is just sort of the burden of disease. Several of them fall within this relative risk of 1. So coronary artery disease, AFib, CHF, pulmonary fibrosis, lung cancer. I like how this sort of pictorially represents that association there. This is not meant to look at in detail. These are just a number of biomarkers that have been looked at in reference to acute exacerbations of COPD that have implications for other disorders. This list is by far outdated at this point. There are many others. So we have a lot of strong correlative evidence. These on the top here, Eclipse, MESA lung, COPD gene, these are large cohort studies. Uplift, TEOSPAR are drug studies. And one common theme in all of these is that there are comorbidities with COPD that are present in increased frequency. And in some cases, these can be worse in certain groups like African Americans. So definitely pays to pay attention to it. Specifically looking at cardiovascular disease and COPD, this is a paper we wrote a couple years ago, and this looked at inflammation that happens in several structural cells in the lung and some inflammatory cells in the lung that have direct impact on the cardiovascular system. So we can see epithelial cells, macrophages, neutrophils, monocytes, and endothelial cells. When these are inflamed, these can certainly in some way, either directly or indirectly, spill over into the cardiovascular system. This is a slide from Gold showing COPD and sudden cardiac death. And there's a survival on this axis and follow-up on this. And we can see if the curve for someone who doesn't have COPD looks like this, those with COPD who aren't having frequent exacerbations have a higher risk of sudden cardiac death. Throw on exacerbations, which is that hugely catastrophic increase in sort of sympathetic tone, and their risk goes way up and their survival goes way down. So what about treatment? So if we treat COPD in patients with cardiovascular disease, what happens? These are from two drug studies from a while back, TORCH and UPLIFT, and there were a number of patients with, all patients had COPD, but it was interesting because in the TORCH study, treating the COPD appropriately resulted in a near significant reduction in cardiovascular death. In the UPLIFT trial, it was significant. So treating COPD may actually have implications for cardiac function and cardiac death. Well, what about the converse of that? Treatment of cardiac disease and COPD. This looks at a number of studies looking at beta blocker use. Beta blocker use, which in most cases was appropriate for people with cardiovascular disease. And a few outcomes improved in COPD, a lower risk of acute exacerbations, a lower risk of death. And there's also data for the renin-angiotensin system. There's some preclinical data, but there's a cohort study about 800 patients who did not have COPD but were smokers. If they were appropriately on ACE inhibition, they had a lower risk of FEV1 decline and a lower risk of incident COPD. So what does this mean? We assess all of our COPD patients for cardiac disease, especially those groups B and D. Those are the ones we really worry about, and we think they sort of hide their cardiovascular disease. We know that controlling cardiovascular disease may improve COPD outcomes and vice versa. And we really pay attention to sort of the unexplained dyspnea that seems out of proportion to their lung disease. And we look for occult cardiovascular disease. Again, just paying attention to these people right here. What about obstructive sleep apnea? A lot of people don't appreciate this. This was a study back in 2010. A lot of COPD patients have overlap obstructive sleep apnea. And this was kind of a nice study in about a little over 600 patients. If you look at survival and the patients have COPD and the patients who have COPD and OSA overlap who are treated, they look similar. When you take that group with overlap that are untreated, their risk of death goes up, their survival goes down. Same thing for exacerbation-free survival. So we do spend a lot of time looking at patients to see if they have, we do a stop bang score on them to see if they have overlap OSA. And then we're also looking for people who sort of have chronic CO2 retention and possibly might benefit from non-invasive ventilation from that standpoint. I just put this here because there are a number of other ones. This is just one example of, this looks at cognitive impairment. It's not well understood. The prevalence probably is increased in COPD. There's actually a number of studies that kind of support that. Again, not well understood, but just probably another example of other extrapulmonary manifestations. When we think about therapeutic considerations, one thing we focus a lot on is inspiratory flow. So we know that COPD patients have respiratory muscle weakness. Many of them are hyperinflated. Many of them are older and they may not have good coordination with some of the handheld devices. And so we do what's called an in-check flow meter on them to look at what their inspiratory flow is. And here's a list of different devices. You'll recognize some of these, where there is an optimal inspiratory flow. And it's amazing when you test patients and they come up with an inspiratory flow of 15 liters per minute, it doesn't make a lot of sense to put them on something like this, when really they're not going to function well until their inspiratory flow is higher. And so we spend a lot of time switching these patients to different medications, mist inhalers, or we might switch them to all nebulized treatment, just so that their delivery is optimal. As I said, we focus on cost of drugs. This is a big deal, especially when you're taking care of a population with a whole bunch of different insurance plans and some who are underinsured. And then we look at things like patient ability, right? Do they have arthritis? Can they actually, use a mist inhaler and click it? Or are they too weak to do that? Do they not have enough manual dexterity to do that? We're always looking at complexity of the regimen's side effect, and we're doing this iterative cycle with them every single time. Do they continue to have symptoms? What's their technique? Do we need to adjust their medication? We focus a lot on non-pharmacologic management. So pulmonary rehab, as you probably are all aware, is a big deal. We have a dynamite group at Davis of really invested respiratory therapists who do just pulmonary rehab. If you look at the data, primary care referrals for pulmonary rehab are low. And there are good benefits from pulm rehab. There are a few studies that actually may show a mortality benefit, but many studies show that patients have symptom control. They gain a sense of community. They can start walking further. And there's a number of things that they can do if they're in a pulm rehab program. The best benefit to that, of course, is if they continue to do it. So most programs are about 8 weeks, but if we can encourage them to do the maintenance programs, they can sustain some of those benefits. We talk about self-directed management. We have a program now where we have some remote monitoring where they can actually download their data to us, and we can start to see if their heart rate's going up or if their oxygen's going down. We often arm people with oral steroids at home in case they start to have an exacerbation. They can self-manage before they actually have to go to the emergency department. Smoking cessation, of course, vaccinations. I'll show you some data about home non-invasive ventilation specifically for hypercapnia. We don't actually, as of yet, focus a lot on nutrition. I know in the cystic fibrosis clinic, they certainly do. This is definitely a future direction for us. We have a robust palliative care program at UC Davis. They're not specific to pulmonary disease, but we do utilize them quite a bit. When we look at this non-invasive ventilation, this is something that is often, if you want to qualify someone for this, it's often enough just to get a resting blood gas, and that can be a venous blood gas. But what's the data behind it? So a study from a little while back looked at very severe patients who had hypercapnia and were stable. And they looked at almost 200 of them. And those that were put on non-invasive ventilation had a lower risk of death in 12 months. When another more recent study looked at patients who had a recent acute exacerbation and then after discharge remained hypercapnic, followed them for 12 months, and those that were on non-invasive ventilation actually had a decreased rate of death. So we do look at that, and we have a number of different ways that we can do this. We have devices that are sort of, something they can clip to their belt, and it can deliver positive pressure and through a kind of a modified nasal cannula, all the way to larger stuff that they may use at night. We focus a lot on airway clearance. There is quite an overlap between COPD and bronchiectasis, and we have a number of patients who have chronic sputum production. As that's the case, sputum clearance sort of makes sense. There's not a lot of great data for it, but anecdotally, and you probably may share this experience, but anecdotally, patients feel better when they can clear their secretions. Certainly they do with bronchiectasis, whether it's CF or non-CF, but they also do with COPD. We utilize therapy vests, we utilize IPV, we utilize a cappella valves, and all sorts of other ones. The evidence is not robust, as far as I can tell. It is there. This is a group of 60 COPD patients that were split into 3 groups: IPV, vest, and standard therapy, which did not include any of the airway clearance stuff. And those who got the airway clearance had improvements in their symptom scores and some improvement in their lung function. I'm not as concerned with improvement in lung function, but if they're symptomatically feeling better, I think that's a good thing. And we do a lot of advanced management in our COPD clinic. So that can be surgical, that can be lung transplant. We have gotten a few patients transplanted at various institutions that do that. We have sent a few patients also for bulectomy or lung volume reduction surgery. But a lot of patients that we see don't quite fit into these categories, or they're obviously not very interested in surgery. And so we have a very robust program for endoscopic lung volume reduction using endobronchial valves. So here's just an example of a couple different valves. You may have seen these in the literature. You may do that at your own institutions. The idea is it's a one-way valve. It allows egress of air, and then when the patient inspires, they don't get air in. And the idea behind this is that if they have emphysematous portions of their lungs that aren't participating in meaningful gas exchange, can we close those down and hopefully improve that? But the real benefit of these, and what was really studied, was does it actually unload the diaphragm? So when people are hyperinflated with COPD and they start to get diaphragmatic flattening, rendering the diaphragm less functional, if we return that to its native shape, is that going to help them? And there's pretty good data that it does. So this is one of the studies. There's two big ones, but this is using what's called the Zephyr valves. And the selection criteria is pretty rigorous. We do follow this. We actually follow this, and then we talk about the patients once we have all the data in kind of our multidisciplinary group, where we meet with the interventional bronchoscopists, and then we select which patients might benefit from this. And in highly selected patients, the outcomes are there. So they improve their symptoms. Their lung function improves a little bit. Their BOD index might improve a little bit, and their exercise tolerance might improve. Again, anecdotally, we have seen several patients who have reduced their oxygen needs, their supplemental oxygen needs. That was not studied in these studies, but we have seen it. So something may happen with their VQ matching that makes a difference. But the caveat here is that the pneumothorax rate with this procedure is quite high. So upwards of 1 in every 3 patients might develop a pneumothorax. We anticipate this. We actually hospitalize these patients for about 3 days because the risk is going to be highest in the first week and certainly highest in the first 3 days. And the idea is in some people, and it's really difficult to sort of predict whom, as their lung re-expands to compensate for the areas that we have made sort of atelectatic, does that put too much stress on their lung and they have a pneumothorax? Our rate, thankfully, is a little bit lower than this. This was what was seen in the studies. And then, of course, we have our registry, and we have over 700 subjects in this now, and we capture almost everything we can. We capture their symptom scores, their exacerbations. We follow them longitudinally over time. They're serologic biomarkers. So we pay a lot of attention to the T2 inflammation to see who might have sort of an asthma phenotype, where we can target therapy for that. Radiographic data and everything else. And this is really a nice repository for us to look backwards at, ask questions, and see what kind of data we have. It also helps us to understand our population. We have several ongoing studies with this right now. We have a few in the works that we're hopefully going to publish in the next year. But we see this really going forward as a real asset. Okay. All right. Well, I'm going to stop there. I probably could have expanded on every aspect of this, but I'd be happy to take any questions. Okay. One I see, will this recording be available after the presentation? I would think so, but I'm going to let Jason answer that one.
Yes, happy to report this presentation will be available on demand. It will typically take a few days for us to do some post-production editing, but it will be available through the calthoracic.org website, and we will also notify everyone through our social media and email newsletter as the channels where you can find that information when it's available.
Okay.
While we're waiting for any questions to come through, I just want to remind everyone to use the Q&A Zoom functionality, hopefully seen at the bottom of your screen. In addition, I just want to take a moment also while we're waiting for anyone to post any questions to really give a sincere thank you to Dr. Schivo. This was truly a comprehensive and educational presentation on COPD care. We sincerely appreciate your time and thorough approach to helping our audience really better understand what you and your team are doing with regard to COPD care at UC Davis. This was really a phenomenal presentation. So Thank you.
Great. Well, thank you. So I see a couple other questions here. Do you refer people at all to Better Breathers, which has been around for 50 years? We do. And a lot of times that comes directly from our POEM rehab group, and our respiratory therapists will do that. So we absolutely do. Another question, how does bronchiectasis fit in the syndrome? As I said, we see a lot of overlap between COPD and bronchiectasis, and some of that's just, bronchiectasis is a sort of a morphologic change, and COPD sometimes is defined as a airflow issue. I would say about 20 to 25% of whom we're seeing in COPD clinic don't have COPD. And it's really interesting because one of our jobs is to tease out that group that doesn't have COPD, but they certainly have uncontrolled heart disease, or they have structural disease like bronchiectasis. And so we end up putting them down sort of our bronchiectasis pathway, where we're looking at sputum cultures, we're identifying if they have a cause of it. Next question, do the road specialists teach bedside RTs to use the in-check dial? Very important question. Oftentimes in-house, patients are weak to begin with. And so if they don't have the in-check valves available, we assume they're weak, and maybe we'll put them on a month of nebulized therapy and then test them once they get a little bit stronger. Next question, your COPD clinic, are you able to share your outcomes? How did it start? We definitely will share some outcomes. We're kind of in the midst of looking at that. We started in 2018. That's the outpatient clinic. The inpatient program started much earlier than that. And it started because there was a need for it, and we had the right person, which was Dr. Louie, who had the vision for it. So he really sort of laid the foundation for it. And then Dr. Kuhn and I kind of went from there. Because it is often coordinated with PR programs, it continues the social support. Okay, good, thank you. This is because it is often coordinated with PR programs, it continues the social support and educational support beyond. That's the Better Breathers. It's great. Next question, what medication will you use for persistent cough and COPD and improving dyspnea? Great question, and that highlights that there is a lot of cough that goes along, not just with COPD, but general pulmonary patients that we see. If I think that they have any modicum of chronic sputum production, or I think they may have structural disease like bronchiectasis, I'll actually try to use airway clearance techniques. I've used nebulized ipratropium with some effect in some people, and the idea is that may confer some anticholinergic activity on their cough reflex. And then, sometimes I rarely will go to sort of some of the other agents like tricyclics or other medications before I've sort of fully worked it up and see where it goes. The other thing I didn't mention here is we do see a lot of people who have concomitant fibrotic lung disease, and cough is a really difficult thing to treat in them. And so when that's the case, we try to identify if they have that. What's your opinion on using inspiratory muscle trainers in this population? I think it's a great area of study. I haven't seen a lot of success with that at this point. I think what I've seen is patients who are able to get medications that are effective and delivered appropriately, who then are able to go to, pulmonary rehabilitation, tend to start to get a little bit stronger, and they might be the group for inspiratory muscle trainers. Okay. Do you use stents for obstructive airways? We do not in general. Our interventional pulmonologists do use stents, mostly for structural disease or cancer or something that's obstructing an airway. We have not used stents extensively just for obstructive lung disease. Any role of yoga? Excellent question. I will tell you anecdotally, I think yoga is great. Anecdotally, I have had many patients, and these tend to be a little bit more motivated patients who have gone to pulmonary rehab, who have told me that yoga was great for them because it really gave them a sense of kind of some neural feedback on how to control their breathing. And in yoga is, one of the parts of yoga, of course, is controlling your breath. And so I think it's a great thing. We don't have anything sort of systematized. I don't know if they do yoga techniques in pulm rehab. That's a great question. Okay, a few more minutes. You're welcome to give your questions there. We got one here. How do the road specialists interact with the bedside RTs with the inpatients? Do they report to each other, communicate with the MDs, hospitalists? Yes, they do. So actually, Dr. Kuhn, who's my colleague, is in charge. He's the MD director of the inpatient road team. And so there is feedback. We also meet, and in fact, a lot of the people who are in the inpatient RT program are also with us in clinic. And so we do meet with them a lot. And there's been this kind of carryover effect where the inpatient road RTs, they're senior RTs for the most part, and they really have kind of spread the message about identifying COPD patients and then educating them and going through their medications to a lot of the other RTs. So it really has been a culture shift. And so there is a lot of back and forth. The other MDs, the hospitalists, they by and large are proponents of this. They see COPD, they know how hard it is. Every year, we're always sort of getting new hospitalists in, being an academic hospital, and there's sort of room for education. But I think we've hit that tipping point. I think we've caught on there. Another question here: for current smokers with recurrent COPD exacerbations who are on triple inhaler therapy, have you seen roflumilast confer a reduction in flare-ups? Yes, I have, and I use roflumilast fairly often. Anecdotally, what would I say? Kind of 50-50. A small percentage of them, I've seen them have some liver problems with it. The GI side effects are things that are a little bit prohibitive in some patients, but definitely in half the patients that I've used it on, it seems to work pretty well. How is the reimbursement? Is there support from government programs? Right now, our inpatient program is funded in part through the hospital. The government program reimbursement, I don't know if I quite know how to answer that. Our outpatient clinics, it functions like any other clinic, and we bill insurances and stuff, but I don't know of any government stuff. We have certainly got some industry sponsorship from time to time. We're always writing sort of investigator-initiated grants. Indirectly, that helps to support the program. Here's a question here. Compliance with home care patients using nebulizers and home oxygen can be difficult, of course. Any recommendations to help encourage them to follow a doctor's orders? Yeah, so this is one of those, this is a problem obviously that plagues everybody. This is one of the reasons why we have started the home monitoring system, the remote monitoring system. In addition to keeping track of patient symptoms or change in vital signs, et cetera, from feedback from patients, it's really given them sort of an avenue to feel connected. There is somebody, and it's usually one of the respiratory therapists who is always available to answer calls for those patients. We try to be available for everybody. Our respiratory therapists try to be available for everybody, but I think it's systems like that where we say, hey, here's something that can monitor you and in some way keep you connected to us. And my guess is compliance will go up. How often do you have PFTs performed? In stable patients, once every 2 years. If they're unstable or their symptoms are out of control, I'll probably do that a little bit more often. But in general, if we're looking for patients who have a rapid FEV1 decline, that is a sort of described phenotype of COPD, we like to at least have it every 2 years on them.
All right, last call for questions. Thank you so much to everyone who's participating. We've got Dr. Schivo for just another minute or two. If you have any last question, now's the time.
One we see here, what is the overall regimen for moderate severity? Corticosteroid plus beta-2 agonist. So it depends, like everything, right? If you look at sort of the gold algorithm, moderate severity is not the only thing that sort of dictates therapy. You would also want to look at what are their symptom scores and are they a frequent exacerbator. I will say that I often will start people on combination bronchodilator therapy, and that's long-acting beta agonists and long-acting muscarinic antagonists. I think they benefit from both. They benefit from the different mechanisms of action. If they're highly symptomatic, it seems to be pretty effective. But again, we look at the algorithm and then we kind of customize it to the patient. Steroids, I really only use inhaled steroids. I really only use them if they have sort of maximized everything else. And I only like to use them if they have elevated eosinophils. Next question, have you considered high flow therapy for chronic COPD patients at home? Yeah, my understanding is high flow is a little bit difficult to do at home. They need an apparatus that really can kind of deliver that. And so far, I haven't seen a lot of success with that. But high flow therapy is great. We do have things that deliver sort of low level positive pressure. There's a device called a Life 2000 that can do that. But that's not really what you would consider sort of high flow. Okay. Has theophylline gone out of practice? I still see patients who are on theophylline, and it's really interesting. I've seen a lot of the patients I've seen on theophylline have mostly actually been more sort of an asthma phenotype, and they don't like to go off their theophylline. I'm not a proponent of it. I don't see a lot of benefit, and I see a lot of risk with using it. But some people love their theophylline. Okay. Well, thank you so much for having me. This was a lot of fun. I would have liked to do this in person, but maybe in the future.
Thank you again, Dr. Schivo, and to all the attendees today for making this such a great collaboration. Dr. Schivo, there was also a whole host of thank yous and appreciative comments in the chat. So I just want to be sure you know
Great.
Our audience really appreciates your time.
Great.
And you see the thank yous pouring in. Hope you have a great weekend. Thank you all for attending, and enjoy your evening, your weekends, your families. And we hope to see you in another week or two at our next California Thoracic Society educational webinar. And one last thank you to Electromed for supporting us to make this happen today.
All right. Thanks again. Goodbye, everybody.